In 2012, the Journal of the American College of Cardiology published the results of the ADAPT trial, and this was a 2-hour accelerated diagnostic protocol to assess patients with chest pain symptoms using contemporary troponins as the only biomarker. Now we have a validation study coming up in JACC, and this looks like it could be exciting. So I decided I would like to invite Dr. Louise Cullen to the program here, Royal Brisbane and Women's Hospital in Australia. And first, congratulations. This was a great study in 2012, and now you've advanced even further. Let's talk about the ADAPT trial first and remind everybody what that publication was in JACC in 2012.
Yes, definitely. The ADAPT really was one of our accelerated diagnostic protocols, or ADPs, that we decided to look at to identify which patients present to emergency departments that simply don't have an acute coronary syndrome or at such low risk that we can manage them as outpatients. Fundamentally, we have a problem in emergency departments whereby we never want to miss someone with an acute coronary syndrome or any other serious cardiac disease. But that really has led us to a situation where nearly all patients are being admitted. We can't sustain that, and we also are doing harm potentially for over-investigation of patients. So the ADAPT trial really was to identify that low-risk group, and we defined them as the TIMI risk score of 0, plus no ischemic ECG changes, and 0 and 2 hour troponin results that were negative based on sensitive troponin assays. And in the ADAPT trial, we were able to identify 20% of ED comers, of ED patients, that fitted into that criteria, who were at very, very low risk of any event with very high sensitivity and negative predictive value. So essentially a safe way to say this is a cohort that don't need that acute admission and can be managed as outpatients.
So now in JACC, what's the validation study looking like?
Well, it's slightly different again in the sense that in the next study that's just now available, we've been able to utilise a highly sensitive troponin I assay, and so there is quite a difference. What we've actually done now is taken patients at higher pretest risk, so not just the TIMI 0 group, but also those TIMI 1 as well, and applying the highly sensitive assay results, which were more precise than the sensitive assay results, has allowed us to double the number of patients that we can identify as low risk. 40% now, and the beauty of this paper as well is we were fortunate to be able to work with Christian Mueller's group with the APACE cohort, and they were able to validate our rule in their cohort with equally good sensitivity and negative predictive value. So we think we've really come upon a way that we can take 40% of the patients out acutely of the emergency department and out acutely from hospital admission at a very early time point, so after that second results eval, realistically about 3 hours after they present, and then manage them as outpatients.
So how have things changed at your facility based on what you have found?
Well, at a number of sites already in Australia, ADAPT is being embraced. And so we are utilising the strategy of the 0 and 2 hour results using a sensitive troponin assay, because that's what has been available at the moment, with the TIMI risk score 0 to move 20% of the patients out of the emergency department. And myself and a colleague, Will Parsonage, a cardiologist, we've been funded by our state government to roll it out across one of the states in Australia. We've also then gone to a number of other sites who are using the sensitive assay who have incorporated that. But just very recently, the high sensitive troponin I has got TGA approval in Australia. And so for those institutions that have got access to this, they're looking at utilising this rule to take 40% of their patients out of an acute admission process.
And this is not a complicated process, correct?
No, it's got to be simple. In the emergency department, chest pain is the leading cause of presentation. It makes up to 10% of all of our presentations. So it is the biggest thing to target. But as you can imagine, in a busy ED, where we really are the jack of all trades and master of none, you've got to give us a tool that's very simple and easily applicable for us to actually embrace it. And I think that's the lovely thing about ADAPT. We've actually published our small pilot study. Where we initially implemented, we published the results from the pilot study, and physicians loved it. They took it up very easily and have maintained it. And I guess that's the other thing. This translation of research into clinical practice change is fundamentally important, and was really exciting with that original JACC paper, and I'm very much looking forward to the impact of this new paper that's online now.
So anything else in your future in terms of where this is going next?
Oh yes, my focus as an emergency physician is a little different to the cardiologists. I think it's very easy to identify who does have the disease, but we need to really be confident about who doesn't. And so what I'm looking at is the other strategies. There's another group of patients that I want to look at now, which is really those people who don't fit the very low risk, the TIMI 0 and TIMI 1 criteria, I believe truly that we can actually accelerate that group's of patients' care already, rather than the traditional process of a fairly lengthy assessment process. I'm in the middle of an intervention trial at the moment, which we'll be finalising in a couple of months. And so far, it's quite optimistic. I think I can impact the care of about 70% of all patients presenting to emergency departments with symptoms of possible acute coronary syndrome.
So in 2012, there was the ADAPT first paper that was published in JACC, and now we have a new one. Please go to JACC and look at the paper. And please look at CardioSource World News for other coverage from the European Society of Cardiology meeting. I'm Rick McGuire, Executive Editor.